Good to go. Brilliant. Well, welcome everybody. Thank you so much for joining us today. A few housekeeping bits. If you wouldn't mind keeping your cameras off and being muted throughout, that would be fantastic. That just helps to showcase the speakers today. We are recording, so you'll see that the recording is on. And if you wish to have captions, please add those in. We are looking forward to delivering this session on a framework for reducing a sickness absence, and looking forward to receiving your questions as well, which you're welcome to add to the chat, and we'll address those at the end of the session if that's okay with you. Bernard, next slide, please. And I think we'll hand over to introductions, starting with yourself, Bernard.
Hi, everyone. Thank you for joining in this morning. My name is Bernard Yu. I'm the Medical Director of PAM Occupational Health. I've been with PAM for 9 years now, and I'm a consultant occupational physician by trade. And over to you, Nicola.
Hi, everyone. My name is Nicola O'Shea. I'm the Managing Director of PAM Occupational Health. I've been with PAM for 12 years and worked in occupational health now for 25. Janet.
Thank you, Nicola. That's quite a track record, really, isn't it? 25 years. I've been with PAM for 17 years now. I'm head of occupational health training. I'm an occupational health nurse specialist by background, and I'm really passionate about sickness absence, so really pleased to be part of the panel today. So hand over to Nicola now to take us through the next slide.
Okay, thank you. Well, so we'll start with some quite alarming numbers, I guess, in some respects, because if we take 2.8 million people on long-term sick at the moment, I think when I saw the statistic of for every 13 people in work, one person is now long-term, we can see why there is a need for some intervention, which we'll talk about in our later slides. 9.7 million people waiting for hospital treatment, and I guess the amount of people on the waiting list in the NHS is also coupled with significant waiting lists of our private providers as well. So that's something that continues to increase. 94% of fit notes are used to sign people off work. So I think revisiting that fit note approach is something that we'll cover off in later slides too. And the amount of money being spent, so 69 billion. And I think the real significant message here is around the level of spend if you compare it to what is being spent on schools and policing. So there is no doubt that there needs to be some intervention. So next slide, Bernard. So what is the government doing, or what is the proposal? So a pilot phase with 15 ICBs identified to introduce a project or a pilot that £64 million has been set aside to spend within this pilot phase, introducing a specialist health and work professional to write the fit notes, and we'll talk a little bit more about what that role looks like. A focus on reasonable adjustments, and a lot of mention is around the mental health and MSK issues, so there'll be a real key focus in those two areas. I guess what we would identify at this stage of what the concerns would be from an occupational health provider perspective, we would see one of the significant benefits is understanding the employee's role and working with the employee and the employers directly. So that isn't going to be something that this service will offer. So you've got that real gap of not really understanding the working environment and no specific understanding of the job role. So it feels like there'll be a generic approach to some of the strategies that will be deployed as part of the pilot phase, and a couple of the key observations there that Bernard, Janet and I would draw out of the pilot is the lack of interaction with employer. Thank you, Bernard.
I'll pick it up from this slide. So just a quick overview of what we're going to be discussing today, that sort of framework for reducing sickness absence, which we found most effective in reducing sickness absence whilst delivering occupational health to many clients over the last 20 plus years. One of the key aspects to success is the strategic relationship we have with employers to both understand their business, but also their people. And that relationship allows us to support clients with each element mentioned here. And we'll be having some examples of how that's been effective during today, some case studies, if you like. Next slide, please, Bernard. Thank you very much. So we've noticed a significant benefit from early intervention, and please feel free to read the full benefits of early intervention report on our website, which really demonstrates quite clearly the effects that this can have. And those of you who have attended any of our previous webinars will know this difference in this study. That study was over 1,600 people that were referred into occupational health, and it found that 91% of those referred, while still in work, could be supported to remain in work, compared to just 47% of those referred after they'd gone absent. Of those absent from work, almost half could be supported back to work with temporary adjustments. Of the remainder, almost 1 in 2 with permanent adjustments, and over a quarter were found to be fit to work with no adjustments required. So if you haven't read that report, I'd strongly recommend that you go and have a look at that report. And just for your interest, that is a report that we've shared with the government when they've been garnering information and case studies. Next slide, please, Bernard. Thank you very much. So overall, 2/3 of employees can be prevented from going absent if they're supported while in work. However, 1/3 of managers are waiting until the employee goes absent before referring into OH. And if I refer you back to those figures from the previous slide, you'll see that does delay that return into the workplace. And this is a huge concern because there's a very clear correlation between when the individual is offered support, typically in the form of adjustments which are reasonable to the organization, or to help them to manage a health condition, and the likelihood of them being in work a month later. And just to illustrate that, after a month of absence, the likelihood of an employee being in work is more than halved, from 91% to just 45% a month later. And after 6 months of absence, the likelihood of them being back to work within a month is just 27%. So I'll leave you to read those figures. But as you can see, that referring whilst they're in work is absolutely key, and referring them well, if they do go off absent, referring them as quickly as possible will help them come into work earlier. Next slide, please, Bernard. And I think Nicola, Bernard's taking this slide.
Yes. So, what about managers? What could they perhaps consider doing in terms of preventing sickness absence? I think the key issue here is to be observant and to look out for what is not usual with your employees, because as managers, you will hopefully know your employees, the way they behave, the way they act, so it's that change, if you like, of that behaviors and signs that perhaps will be key here. So, for example, you could spot somebody struggling with cognitive difficulties, like the memory going off a bit. Nicola will know my memory always goes off anyway, but then so that's a separate matter. Poor judgment, maybe one of those. The individual may come across, as feeling a bit lonely, or may express that a bit of nervousness and agitation. From a physical perspective, are they having problems with moving about more freely? Are they complaining perhaps of more pain in their musculoskeletal system? Yeah, so joint pains, perhaps the appearance of a rash suddenly, they may not even bother about it. Maybe they look a bit unkempt and they're not as bothered about how they come across or they present themselves to others. Again, behavioral issues, could include, as we say, some work performance thrown into it as well, like increased errors being made, not doing certain things. So, these are the that of course the scenarios are pretty much endless. Yeah. So the key here is to, observe. Yeah. And when there's something that you don't feel quite right, then open up the conversation, the supportive conversation, and this, ALEC method supposed to be, working well. So it's about firstly asking general, and appropriate questions, just like how are you feeling, what's going on, and trying to engage your employees that way. But again, the key here is listening and paying close attention. It's no point, trying to mother them or telling them what to do, because at the end of the day, your employees, most of them will already know what they need to do, to improve their situations. A lot of the time, this is about nudging them. Yeah. So giving them that encouragement and to say, have you reflected? And then, encourage them to take that action. And following on from that is that checking in, perhaps signposting them to, your intranet, or if you have services, like your employee assistance program, AAP, or, physiotherapy. But of course, not to sell ourselves short in OH, and early occupational health referral will also, should also be considered.
Bernard, can I just add in, just before I start on the NTW slide, one of the programs and education packages that we offer with one of our colleagues, Kathy, is a really well attended upskilling of managers session around difficult conversations. And what we're always looking for from our clients are ideas around how we can help you, but also help your manager population to make a good referral and to understand what questions to ask, and when the report is received, how to interpret that report and have a really supportive conversation with their member of staff. So we see really high numbers. It's probably one of our highest attended training sessions that Kathy delivers. So we really recognise that that is an area where we can offer some real support to be able to navigate and support the manager in delivering the information that we put in our report. So just so you know, that is something that we do offer, and that is something that we can assist with. Okay, thanks, Bernard. So we've got a case study here, and this is just a really I would say a snippet of some of the case studies that we could share as well. And I can see a comment around sending the slides out. We maybe give some other case study examples as well as this one. But if we just focus on NTW Solutions, this is a provider of housekeeping, portering, catering services into the NHS, and they approached us around what we'll call the challenge. And what they wanted to do is really engage their workforce to be proactive around staying in work and identifying those early signs like Bernard's just talked about. So we looked at some of their absence data and some of their health conditions and some of the reasons why their people were presenting sick. And what we did was encourage a real early intervention. And this is probably something that we in occupational health would think is a really obvious thing to do. Early intervention is something that we absolutely know garners some really great results, but not every organisation is necessarily adopting that early intervention. Their triggers might well be to refer when somebody goes off sick. So this client was really particularly engaged with having an early intervention process. So managers were encouraged to refer anyone who didn't feel right in themselves into PAM OH. So as well as OH, the day one absence service was implemented. And having that early access to mental health, counselling, physio, and anything that really presented on the day one line, we would signpost through to implementing support as early as we could. And we've seen some real benefits, and without sharing the specific numbers and percentages, the absence is significantly dropped, and there's a real obvious link to staff turnover. So the clients worked with us on this case study, and throughout we've measured results, we've observed changes throughout that process of what's worked, what didn't work. But ultimately, this, as well as many other case studies that we've worked with our clients to document, early intervention has definitely been a thread throughout, and getting support whilst people are identifying and presenting at work with something that would potentially lead into an absence in the future, but identifying and supporting them whilst in the workplace. So just to reinforce what Bernard said, just spotting those signs and engaging occupational health at the earliest opportunity. Thanks, Bernard. You're on mute, Janet.
Someone mute. There always has to be one, and it's me today. So reasonable adjustments to reduce absence. Actually, Bernard, you were taking this slide, weren't you? So I think I'm talking in your turn.
Oh, am I? Oh, okay, never mind. I didn't realize. Again, another technical issue, or this time human error.
Human error.
Yeah, I mean, reasonable adjustments. I think again that is up to you as an employer to decide what is reasonable. But these are just a few examples of what you may consider to be reasonable, i.e., a change in their working hours and pattern, changes to their working environment and conditions, modifying roles and responsibilities, regular check-ins, and providing a buddy and mentor.
Bernard, if we go back on that slide, I'll add a little bit of meat to the bones on that one, if that's okay. One of the things that it's great when managers do pick up that there is an issue and are able to have that conversation. But we know that 1 in 3 employees have actually not discussed their health with their employer. And these employees might actually be putting on their "I'm fine" mask and trying to carry on until they can't cope anymore, and then end up going absent. And those are the ones where it can be quite tricky. But once that courageous conversation has been had, or whether it's a referral into occupational health because they're noticing that things are going wrong and they've had that discussion, then actually these elements that you've been talking about, the working hours and patterns, and the working hours could include sort of things like frequent breaks, flexible hours, time off to attend medical appointments, and changes to their working environment could be sort of, perhaps relocating to a workspace that's quieter, or to reduce sort of sensory demands for those that have a neurodiverse condition. Maybe providing a rest area away from main staff, maybe a reserved a parking space, modified roles and responsibilities, deadlines, volume of work, reducing customer-facing work. There's quite a lot of things that we can do in order to be able to support. But I just wanted to pick up on the regular check-ins. Those regular check-ins to assess progress are absolutely essential, because what we find is that if that doesn't happen, then the person doesn't feel supported, they feel left, and then they can end up going off work, or alternatively, those adjustments can remain and actually the situation has changed and they may not need those adjustments anymore. So those regular check-ins are essential. And I know there are some organizations that use a WAP plan, or a wellness action plan, or wellness recovery action plan, but that needs to be addressed quite sensitively, as it really does require the employee to focus on self-management as well as what adjustments in work can help. And certainly this is something that assessing the applicableness of is undertaken by OH, and sort of introducing the subject for the employee. So that's just what I wanted to add on to that slide, if that's okay.
Thanks, Janet.
And I'll take the next slide as well. As the government has already identified with GP fit notes, it's not, reasonable adjustments are not as easy as it seems, especially coming up with adjustments that work for both the individual and the business. And so this is where, we occupational health professionals who have that clinical expertise and understand how someone's condition might be hindering them at work, but also are expert in understanding the effects of work on health and health on work, can be helpful, not least because they're in communication with the employer. That referral from the manager gives them the clarity, or gives us the clarity on the situation in the workplace and the demands of the role. And certainly something that PAM offers, which are our briefing and debriefing calls, enable that extra insight, if you like. We then conduct a clinical assessment to determine what people can do or can't do into work. And just to mention again, taking into account the job demands, but also any safety critical elements. So where other people around them might be affected, or perhaps the general public may be affected. So for example, if somebody's lost their tolerance and may not be able to cope with certain phone call situations, or maybe in a safety critical driving role, etc. There's many such type of roles. And we can suggest what reasonable adjustments there could be that keep them in work. Or perhaps we can suggest that access to treatment such as emotional counselling or physiotherapy, or a pain management specialist. And certainly within PAM, we also have a wellness team that can support people with managing their own health. Because we talked about, it's not just about the adjustments, but it's also about helping that person manage and understand their condition more. Sometimes people might need temporary adjustments, or sometimes they might need permanent adjustments to be able to return. And in other cases, we may very well be able to communicate with their primary or secondary caregiver to support, treatment options, or signpost them to that self-care, when I was talking about the WRAP plan previously. I'm just going to give you an example of adjustments for someone who perhaps is waiting for a knee operation. Perhaps they need to have their desk moved downstairs, or given an opportunity to work from home, so long as the role can accommodate it. These adjustments are communicated back to the manager to ensure that they're reasonable and actionable. And then hopefully the employee can either remain in work or return, or if those aren't reasonable, then perhaps their return can be planned for a later date, or perhaps we might say that they're unfit to work. But something that we find that some employers think when somebody's got planned surgery is, perhaps there's no need to refer into occupational health until after the surgery, until the person is recovering. There's nothing we can do. But actually, that's not the case at all. We can support those people with prehabilitation, understanding what they can do to prepare themselves for the surgery, to support their recovery afterwards. But we can also set expectations. So there is, evidence-based for return to work, different types of work following certain types of surgery. So we can, educate the employee on that, and we can educate the employer on what the expected return to work time scales are. And this is where we can support with that sort of vocational rehabilitation perspective, by enabling people to understand that actually an earlier return to work can be possible with certain adjustments. And certainly people find, and that's part of vocational rehabilitation, is that returning into work can actually hasten up, or a recovery can speed up a recovery as people get into a better structure, and as they gradually, increment up their activity. Next slide, please, Bernard. Hopefully everybody's had time to read that. So what we take into account with individuals is that biopsychosocial model. We're looking at the biology. What is the health condition? We're looking at their health. We're looking at their psychology. We're looking at their social context, and the crossover of all of those. Certainly one of the potential drawbacks in sickness absence management is medicalizing an issue, or only seeing one aspect and therefore signposting people into a particular specialism. And that might be, or they need mental health support, or they need physio support, or they need one type, where in actual fact, human beings are complex, so they might need several different elements going on in order to help. And just to give you another case study, we deliver a fantastic service for long COVID. And what we found is, even if a person hasn't got psychological issues, actually getting psychological support to come to terms with the condition actually helps them with their recovery, and helps them with the physical aspects. So providing that sort of physiotherapy, breathing support, the wellness support with their health and nutrition, and psychological support actually had much better outcomes, even if somebody didn't score highly in having any impact on their psychological health. So we're one whole person, and it's really important to be able to see that. So, for example, somebody who might be going through cancer treatment, which also causes quite significant fatigue, same as long COVID, and reduced immunity, they might be very worried emotionally, but also might be having to learn how to eat a more nutritious diet, manage their pain and discomfort, and lean on others for support at a time when actually they least feel like doing that. And sometimes their confidence of coming back into work is reduced, so therefore getting that sort of maybe psychological support for confidence coming back to work, even though, as I mentioned before, it might not be an actual psychological condition. But similarly, someone struggling with anxiety or depression can benefit immensely from having more positive interaction with others, getting more fresh air, exercise, increasing their time in nature, improving their general health with their diet, their nutrition, their sleep, and hydration, all of those different factors. So although managers have an important role to play in making reasonable adjustments, occupational health help by looking at people in the round, that biopsychosocial model of health, and advising support for them as a whole person. We understand the complexities and the relationship with work and health. For example, a person may feel that they can't work, whereas perhaps with discussion and support, we can demonstrate that they can work, and that's that we've managed that time and time again. We also facilitate that relationship between employer and employee, enabling the manager to understand those sort of biopsychosocial effects on the individual, and therefore helping to build not just the confidence of the individual, but the confidence of the manager, because a manager is, it has an enormous role to play, and whatever support we can deliver to that manager will ultimately support the employee and the organization. And another just aspect to touch on is that it's particularly important when you want to move people off reasonable adjustments onto full duties. So, for example, they maybe have become used to reasonable, those adjustments in place, whereas in actual fact they've now got to a place where they no longer need that, and that's where we bring into play that sort of the psychosocial aspects of help. of health and help them come and get back to full duties. I think it's over to you, Bernard.
Yes. Thanks, Janet. So in this next part, we have 3 case examples, sort of following on from those case examples. Hope you're not all case examples out by the end of this, but we do, we persevere. So in this first case, we got a chap by the name of Christopher. So he is a 45-year-old gentleman. He works as a prison officer. He works full time and does a shift pattern work. So as a prison officer, last resort, you have to restrain the inmates. So what happened was he noticed the onset of lower back pain, leading to a period of sickness absence in the last 2 weeks. There were no triggering factors of note. He had 2 previous self-limiting episodes. His back pain has improved over the 2 weeks and is currently described as in the mild to moderate range. His difficulty is predominantly with tasks related to bending his lower back, like gardening and putting on his socks and shoes. He also mentioned struggling a bit with prolonged sitting. Christopher is a bit worried about the impact of his job on his lower back, and notably that restraining bit. He also had x-rays undertaken by his general practitioner, and in his age group, it's not uncommon to see a couple of degenerative lumbar spine vertebrae in his back. So he came throttle on to for OH consultation, and as Janet mentioned, our clinicians adopt a biopsychosocial approach in the consultation. So during that consultation, our clinician reassured Christopher that his low back pain is not harmful, and there's much to be gained by strengthening his core musculature in his back. There's no good evidence that the role itself will harm his back or cause recurrences. Our OH advisor also emphasized that the overprotection and the unhelpful beliefs are likely to be more harmful to him in the longer term. So what were the occupational health recommendations then? So we advise a discussion regarding a return to work take place, and it's a good idea to have that scheduled meeting in advance of any return to work. A swift return to work is encouraged, but whilst that core strengthening of his muscles take place via physiotherapy, then to temporarily refrain him from restraining inmates, in this case for 4 weeks, with timely physiotherapy access. Now, this employer had access to, talking therapies as well as physiotherapy. That therefore is a referral to physiotherapy, and also to consider referring him to the EAP service to address any lingering anxieties. And it would also be prudent for any training to be updated, including having proper restraining techniques. So again, with any occupational health consultations, expect that advice will be given to the employee for any self-help measures, including the appropriate signposting. The clinician has also advised, regular mobility breaks to negate being in static, prolonged static postures. And if there were any further concerns, to refer back to occupational health. So example 2 is another chap by the name of James. He is a 38-year-old teaching assistant with a primary school. Again, a full-time employee supporting school children with their educational needs. He has a 7-year history of anxiety and depression, and that's generally well controlled with medication. However, on this occasion, he's been absent from work for the past 3 weeks as he perceived an increase in workload and having to cope with family illness. However, care plans are in place and instituted by the local authority for this particular family member. Nonetheless, he still describes his mood as variable in terms of day-to-day activities he is managing, but still lacks motivation at times. He feels overwhelmed. His sleep pattern was affected initially, but it is improving. He had initial thoughts of self-harm, but has good insight. He states that his family is a good protective factor, which is why it is very unlikely that he would do anything to himself. He feels a bit anxious about returning to work because he still perceives significant workload issues. So he trotted along to an occupational health consultation where, our clinician adopted a motivational type interviewing technique and emphasized the importance of the beneficial effects of returning to work in order to keep the length of absence down and to maintain function. So in terms of recommendations made, our clinician advised, again, a planning of a return to work. But in this case, you don't need a lengthy, graduated return to work program. Just a short one will do, with regular meetings with the employer and also to undertake a formal stress risk assessment. So in the case of James, to support him with any ongoing treatment process, because he's currently having some talking therapy through the NHS. So it'd be good, if he could be afforded time to attend those sessions. But again, the key message here is early intervention. So to encourage him to come forward with any issue which he has for further discussion and support where necessary. So it can be something just as simple as a discussion, with resolution. Is how underrated these simple discussions are. That is amazing. And if it needs a bit more, then you can do a formal stress risk assessment or a review of that stress risk assessment. It may also involve early OH intervention for further advice on his health status and any support mechanisms. So again, with every occupational health consultation, expect the employee to be advised on self-help measures and any treatment review suggestions to be discussed with the employee's treating team. There may be times where occupational health may opt to write directly to the treating team with consent, above where that sharing of occupational health report with the GP, which we always encourage the employee to do anyway. So this next one, you'll be happy to know if the third one, Cynthia. So she's a 52-year-old medical secretary with no previous mental health history. She's currently at work, but in the last few months, she feels anxious and low in mood. She has been struggling at work, finding it overwhelming, and her performance has been impacted. She feels that she can't cope and her sleep is adversely affected. She was referred to occupational health, where our clinician again adopted a biopsychosocial approach during the consultation. And in considering this holistic approach, suspected that, well, actually this could be a menopause rather than a psychological issue. So the clinician went on to use the menopause assessment checklist tool, and that indicated that it could be the menopause. So what did occupational health recommend? So our occupational health clinician advised the employee to consult a general practitioner to discuss a more formal menopause assessment and have her treatment reviewed. So she was on treatment which focused, just solely on psychological problems. Again, but menopause is, as we know, it's a more wider issue than that, and the psychological component is just one element. So her current treatment is perhaps not as effective as it should be. So she was again encouraged to share the occupational health report, and in it there is also with the GP, by the way, and in it there is also mention of signposting to reliable menopause websites and self-care information. So such awareness in the report will also assist in manager upskilling. The occupational health clinician advised temporary reduction in workload until her GP has reviewed and put in place a more effective treatment plan. With effective treatment in place and a health better managed, a gradual increase in workload can then be explored. We also advised regular catch-up meetings to ascertain progress, notably during the period when her treatment changes and change to her health is occurring. And until such time as it has improved and stabilized. Occupational health also advised on undertaking a stress risk assessment and advised on the use of a wellness action plan. And as what Janet has already mentioned, PAM, we have guidance and tools both for the stress risk assessment as well as the wellness action plan, which we share with employers. So in this case, OH to review progress in 6 weeks, and this is another example where support and early intervention is likely to reduce the risk of sickness absence. So, Nicola, I think this is yours.
Over to me. Yes.
Yeah.
Thanks, Bernard. So these are 3 areas, but there are many more. But I think when we look at identifying any organisational factors that may impact sickness absence, I think we collectively agreed after discussing what we see most frequently occur in terms of patterns and trends is the employer adopting best practice. So we all know where legislative requirements, health and safety practice, just generally all of your people strategy, is that best practice embedded within the organisation, and is the employer following that best practice? So that often comes through as patterns and trends in our management information when we're non-clinically looking at the behaviour of the contract and what we see as outcomes. Then we would definitely see the best practice being implemented as a real positive environment for a healthy workforce. The culture, is the culture a supportive culture around employee wellbeing? There's so many facets to this point. What does that mean? What is a positive culture? But we certainly see where there is a real focus on employee wellbeing all the way through the life cycle of your employment, from how you enter the organisation, your pre-placement screening, how the advice around adjustments is taken on board in those early stages, all the way through to some of the themes we've talked about around management support, any adjustments that are required. And we also see, Janet touched on it earlier, where we see a lot of referrals into occupational health that are not health related. They could be relationships that have broken down in the workplace, relationships with managers, colleagues, etc. So what is the culture of the organisation promoting in terms of the well-being of its staff? MI really plays a big part in trying to assess the culture of an organisation, because you could see how we at PAM break down our management information for our clients to assess where there's patterns, trends. We could look into particular divisions, departments, and even down to teams if we're seeing patterns of the same type of referral reasons coming through in particular areas of the organisation. We can drill into what's happening in that area and talk to the client and collaborate with the client on possible themes and patterns that we're seeing. And ultimately, a really big player in obstacles could be around the sick pay scheme. So is the return to work focused in on what that sickness pay scheme allows? So there's certainly some patterns and behaviours that we will see around the organisation's scheme and how they pay sick. So that's certainly something that we see. So whether when we work with a new client, we will ask to see their sick pay schemes and really try to understand if that's likely to feed into any of the behaviours that we might see around people being off work and the duration of how long people are off work. And one of the things that is really intelligent within our management information is seeing the follow through. So if, for example, we have given advice in a report to say that this person could be back at work immediately, if we review your absence with you and see that that same person has not returned to work when they could be back at work, that can drive some different conversations around what that means in terms of that person's appetite to return to work, and is it linked to the sick pay scheme. So there's many layers to the management information of your occupational health provider, telling you what patterns and trends are coming through around any organisational factors. But these are maybe three of the key areas that we would look at when profiling some of the reasons what might be impacting attendance within our clients' workforce. So Bernard, Janet, there's so much discussion around this point. I took the slide, but your contributions, any other thoughts around these three areas?
I think you hit the nail on the head by saying data. Data is absolutely key, and it's certainly something we're really passionate about in PAM, as you've mentioned. But data can identify those organisational factors. So I think that was one I suppose just wanted to emphasize from my perspective.
Yeah, I think as you mentioned, the culture, supportive culture, top down, that's the important thing, because without senior management supporting that, is doomed to fail in the first place. And I think there's quite a lot of evidence, in a supportive environment. Then I think, not only does that affect positively on staff turnover, but it will have an impact on sickness absence as well. So yeah, sorry, I can't see the chat because I'm sharing the slides. So
I think Janet's keeping an eye on the chat. I think
which is a good thing. So
one of the case studies that we have worked with one of our clients on is around identifying some particular patterns around reasons for people being referred associated with the environments they were working in, the culture of the organisation, particular departments where there was a culture of excessive hours and potentially a higher volume of burnout related cases coming from particular areas of the organisation. And what we really we were really motivated by an action that came out of sharing that information, because they went through an organisational wide culture creation exercise. So they actually consciously wanted to start driving change and creating a culture, rather than culture being something that was being led by individual leaders in individual areas. So the organisation wanted to take control of how they were going to create a different type of culture. So it's really great to see where occupational health is traditionally seen as your health and wellbeing provider. We like to think that we go a little bit further into the organisational dynamics and just try and share information and see where that takes the conversation. But in particular, that culture, there was an action plan, and outcomes of that action plan were around management training, sharing examples of what supportive cultures look like, again, the mention of those supportive conversations. So yeah, definitely the culture piece has a really big part to play on how people feel about being in work.
Thanks, Nicola.
Okay, thank you.
Yep. So so what would be the key points in terms of reducing sickness absence? So we've been through all this, the focus on early intervention to keep people at work, upskilling managers so that they can spot symptoms and signs, and then to open up that conversation. As I said before, it's incredibly effective. Yeah, just that simple. How are you doing? How are things regularly, but more so if you feel something is not quite right, just open up. And if you're consistent in doing that, then I think that skepticism from the employee will be reduced. Yeah, sorry, something happened there, but never mind. Hello?
We can hear you, Bernard.
Oh, you can. Sorry, something
Yeah.
happened. I thought I got cut off. Okay,
No.
sorry. So yeah, and again, support your employees where you can with reasonable adjustments. And in our study, we've shown that by offering this or by doing this, you actually reduce absence by 2/3. We've already mentioned organizational factors, and ultimately it comes to occupational health, and we adopt a biopsychosocial model and so motivational interviewing, sort of assessment tools, recognized assessment tools to try and achieve the best outcomes for both the employer and employee.
Thank you, Bernard.
Thank you very much.
So we come to the questions and answers, and we have had not really a question, but more of a comment, which is really useful for us to get that feedback. So thank you very much for that. It's certainly something that we'll look into and see what happened there. I mean, we do have a feedback system, PAM Listen, which we absolutely encourage all of our customers to utilize, because it's through that we collect our own data to be able to see what's happening within, for our clients, so that we can focus any improvements. So Fiona's asked, you mentioned stress risk assessments and WAPs earlier. If you have had any examples, are you able to share these, please? It would be good to compare. We do. So if you're a PAM customer, we do have a WRAP plan in our guidance for customers on our higher support section that you can have a look at. we usually signpost our customers to the Mind guidance for wraps. So if you're not a customer, then please contact us. I mean, there's a slide, a couple of slides on. I don't know if you want to move the slide on to the end one, the PAM Academy, people@am.com. So if you have any other questions that we haven't covered or anything that you would like us to share, then please email us at PAM Academy, and we'll certainly do what we can. But if you are a customer, the RAP plan guidance is on there, but also the stress risk assessment guidance. So there's guidance for both. It's easily searchable. You just put in stress risk assessment. We call our wellness action plan a wellness recovery action plan. So if you just search for WRAP, it should come up straight away. So the next question is, how do you approach a situation where a staff member is very keen to return to work, yet they are not accepting that they haven't reached? That's a really interesting one. And I think this is one where actually occupational health can help. So Bernard, I'll hand this question over to you, if that's okay. If you can't see the chat, it says, how do you approach a situation where a staff member is very keen?
Thanks, Jenna. Yeah, I mean, it's just like any other occupational health assessment. You know, we do that assessment objectively, and we look at the medical issues, the ability to function, you know, what their symptoms are, where they are in terms of treatment, are there any further beneficial treatments, and if they are, you know, they are not they're not in a position to return to work, then, you know, we will say so. Yeah, in our reports, we'll say so. Now, what if the individual feels that they can return to work? Now, difference of opinion, if you like. As an occupational health clinician assessing a case, the first thing we need to determine is that person safe to return to work? Yeah, safety is by far the most important consideration. So if the person is safe and, you know, they need adjustments, so you know, we may say that, okay, this person is safe to return to work. The issue now here is, how are they going to fare when they return to work? Are they able to you know, tolerate, or are they able to you know, the sort of tolerance to symptoms and things like that is quite difficult to objectively measure. But say, for example, if you've got somebody who's just had a heart attack, okay, and, you know, wants to return to work after a couple of weeks to a safety critical and manual work, you know, and you know, they're insisting on it. Now, you know, it'll be quite clear that occupational health will say no, okay, because that individual is not safe to return to work. Now, if there are areas where it is not entirely clear, because let's be honest here, okay, we don't have the person's medical records. We only have what the person tells us. So we may at times have to collaborate with the employee's general practitioner or specialist, you know, to get that evidence. Now, we don't necessarily ask for the opinion, but we ask for the evidence. So, for example, they've had investigations done, you know, they've had, so we don't have access to that, you see. So we will ask for further medical evidence, and we will look at investigation results. We look at, you know, for example, reports that go between general practitioner and, the specialist and general practitioner. And, you know, especially with really contentious cases where it is not particularly clear, then I think this is where that collaboration helps. But cut a long story short, if there is safety concern, you can be sure we will say no, okay? It becomes slightly more, if they really want to return to work, it is safe, but whether they can tolerate or that can cope with the return to work, again, we should give you some indication that, look, this person is going to struggle, right? And we feel that, he or she will not be able to cope. However, this person really wants to try, right? And we will say that in the report to say, ultimately, you have to have that discussion with your employee. They're safe to work. You can try these adjustments, but whether they succeed or not, you can't really objectively measure that, but you can give it a go, give it a try. It is safe to give it a go. I mean, does that answer the question?
And Bernard, just to add to that, I think there are situations that we come across where an individual might be saying one thing and the employer is observing another thing, and we in occupational health are ascertaining. So they may be telling us one thing, but they may be telling their employer the other thing. And we go out and get further medical evidence. But sometimes we have case conferences, and I know those on the DWP call case conferences, where you have a sickness absence review. So there's different terminology, but sometimes it can also be really helpful for all of us to get together. Occupational health, the employer, the employee, their representative. And have a joint discussion. Do you feel that can be helpful in situations?
Absolutely. I think especially where there is sometimes in referral letters we don't get that. All we get is that the employee wants to return to work. So what you advise. Then case conferences, as you say, Janet, they are particularly helpful where in the referral letter we find the employer stating, look, these are my concerns, right? This guy wants to return to work, but these are my concerns. So in that sense, we can still go ahead with organizing that assessment, but you're right, if we can follow that through with a case conference, and so we can look at the views from both sides, and then try and objectively advise the employer that way, because sometimes it doesn't come across clear enough, if you like. You have only finite amount of things you can put in the referral letter. Sometimes having that open discussion between employer and employee, to try and make sense of the issues on both sides, I think is really helpful. So in the way how PAM does case conferences is that we have a consultation with the employee first, and during that consultation we tell them that, look, this is going to be followed by your employer coming in, so we get the consent all done, that they are happy, for that to go ahead, and to also realize that there may be quite a bit of areas that will be discussed, so and they're okay with it. So it's very rare that employees don't agree to that. So in our experience anyway, so I think having that added dimension and not just occupational health consultation will help.
Thanks, Bernard. That's really helpful. I think as a somebody who attends a contract review meetings, and over the years that I've been here at PAM, I've met with lots of clients in different settings, whether in account management meeting or re-tender scenarios. And one of the things when it comes to our approach in clinic is that our clinicians should summarise, so there's no surprises. So the point that was asked earlier that Bernard's just explained is, if somebody has an appetite to be back at work and there is no risk or safety issues, like Bernard said, we would hope that that conversation, the report that's produced and sent to management, is seeking and agreeing with the individual what they can and can't do. So there isn't a report that you receive and then a difference of opinion from the employee. So that's something that has come up in various meetings where they feel that there is alignment between the report and the perspective of the employee. So that training and the Academy's approach to upskilling our clinicians is around making sure that the individual goes away and there will be no surprises in the report, and that there's real collaboration in producing that opinion so that it's agreed on both sides. So that has been a thread of feedback that we do get. But as Janet rightfully said, the PAM Listen feedback and our account management meetings are there if it is a PAM client, where we want to hear how are we doing, are we delivering a service that is really fit for purpose and producing good advice that is actionable. So thank you for all the questions as well. I'm trying to answer some of them as we go along. Janet, you're on mute.
Again. We're about 7 minutes over. So I think just that one question, which is the route for contacting someone if we haven't received the pre and post call. We can answer that in the chat, can't we? Because I think let's bring it to an end.
Yeah, well, I'll respond back to those where I've said I'll send a direct email, because I think the feedback's really important, and we do have many channels to identify. If you didn't get a pre or post call, then we'd be able to see why that happened. So I'll reach out to those that have asked those questions and get back to you with some feedback, and also respond with best channels, Emma, to give us that feedback. So and if any questions come in after, we'll stay on for a few minutes after and just respond and get back to people. I guess that just to sum up and close from my perspective, if anybody has any questions after this session, please feel free to reach out and ask and approach. I hope you don't mind, Janet and Bernard, that I'm offering direct approach to all three of us if there's anything that anyone would like to ask outside of this setting. But feel free. I think our emails will be in the body of this invite. But thank you for attending and listening. Thanks, Janet. Anything?
Thank you very much. Thank you, everybody.
Yeah, thank you very much, everybody. That's great. Yes, and we'll definitely share the recording and the slides. It might take a week or so for them to be pulled together and just edit out that beginning, because I started the recording quite early. And then we'll make sure it's sent out and it's put onto our PAM Group YouTube site as well. Just wanted to pick up on something quickly. We do have other recorded webinars, so please feel free to tap into those. And as Nicola alluded to previously, we have some fantastic training sessions that we deliver out to our customers and clients, especially around upskilling managers. We know it's a tough shout for managers out there these days, so anything that we can do to help, and we've got wonderful expertise within the team to do just that.
Thank you. Thanks, everybody. Bye now.
Brilliant. Thank you very much.
Thank you.
Bye.